this degenerative cascade. And so instead of trying to use that, like a slip disc or all these layman terms, we simply just say it's a degenerative disc disease where the disc is come down. Now, a couple scientific nerdy stats for the readers out there. Most of the time we see some type of degenerative disc disease or low back issues between 30 to 50 years of age. That's the common age range. We call that the accumulation phase of life. You get that?
You accumulated some back pain.
Yes, exactly. And so a lot of people, they start their careers, right? They have children. They buy homes. Stress. They're trying to retire. So you have this accumulation phase where a lot of times we see. A lot of our clients, they become more sedentary. They're working at the desk a lot more. They're not, their daily practices aren't as active. So between 30 to 50 is in general the age group where we see a lot of low back disc issues.
Interesting.
Yeah, and then another thing too is two things just to be kind of, if we're going to nerd out here today, is most disc bulges only occur on one side.
Oh.
Okay, so a lot of times people will get one-sided disc issue. Okay, it's kind of weird on how it does it, but most of the time that we see in clinical practice and it's reported by the medical doctors and stuff is that the disc typically bulges on one side. Okay, so usually they'll get one side that affected more than the other. If both legs start to have symptoms, then we get worried that it's breaking all the way through. Does that make sense?
Oh, yeah.
Yeah, because anatomically in the low back, our ligament structure gets thinner from L1 to L5, so we don't have the support that we have. So usually, if the disc gets kind of worn out, it'll hit what's called the anterior longitudinal ligament and the posterior longitudinal ligament are the supporting structures. It'll hit the ligament and bulge on one side.
Okay.
So I think that's kind of interesting to know because the low back, if we're doing like the joint by joint approach, the low back is meant to be more stable. It's not meant to be twisting and bending like it does because right below that we have a ball and socket joint. We have the hip.
Highly mobile.
Yes, very. And so I think it's important to understand that degenerative disc disease, right, it occurs primarily between ages 30 to 50. That's kind of a common general thought. We know that a lot of people get one-sided or unilateral disc bulges, okay? And also, too, we understand, too, that if the symptoms, the lower the symptoms are in the leg, that means the lower the disc bulges or the pinching of the nerve.
Oh.
Okay, so for example, when we're looking at our differential diagnosing, I think that it's important just for fitness professionals just to understand it.
Yes.
Is that if I had a disc bulge at L1 and it was pinching the nerve root, let's say the right side of L1, I would get groin pain. But then L2, L3, L4, all the way L5, it goes lower. The symptoms with each spinal level will give me symptoms lower down the leg. So the lower the disc bulges, the lower the symptoms are in the leg.
Okay.
And so I think it's because, so for example, if someone's complaining of numbness or tingling or pain that goes all the way down to the foot, the fitness professional can consider that it might be coming from the low back. And be careful, right? Okay. So I think it's important for the fitness professional to understand that the body's trying to talk to us with these symptoms. That's what the body does. The body tries to communicate with pain, numbness, or tingling, and you have to kind of decipher where it's going. But in general, though, L4 and L5 are the most highly injured vertebral levels in the low back, and those refer to the lowest point, which is your foot.
Okay, interesting. All right, well, so here's something that I know. I'm pretty sure degenerative disc disease is why I am now shorter than 5'9", and I also only thought that happened to get older, not my age older, but now what you're saying is that between that age of 30 and 50, it does kind of make sense that some of those spacers in between the vertebrae would start getting a little bit thinner. And then the other thing that we need to really keep in mind is just pointing out the pain, and that when there is pain, this is not a time to work out, but it is time to refer out. Also want to point out something that I thought was interesting, and want to have you speak to it. I've heard that there are a lot of herniations that, and in people across society here, and they don't even know it. They don't feel it. There is no association of pain. Is that correct?
Yes. There was a couple landmark MRI studies that imaged thousands of people. They found people with their backs look like they were 90, like ready to really, like, they would be a surgical candidate if you saw the MRI. Zero pain.
Amazing.
Yeah. So again, it comes down to the type of activities I think we do. You know, if you have the weekend warrior who's doing a lot of boot camps and who's very physical, their low back pain may be different than someone who just, you know, does your traditional cardiovascular first and then your weights next, you know. So it really depends on what we do, but there's plenty of people out there with, you know, worn out backs, worn out joints who actually survive and they have no pain and they actually last. So that's the challenge of low back pain, is that we can't prescribe, you know, blanket exercises or blanket correctives for, I mean, there's some general things you can do, but you can't prescribe everything for everyone across the board because it's such an individual diagnosis.
Right. With that being said, though, we want to arm personal trainers with something. And if they're following the OPT model, there are a lot of people out there that are going, well, I wonder if I can do stability exercises. But I will point this out, and I want this to be known. If you do an exercise that is supposed to work, but it hurts them to do it in their low back, it is not the right exercise. And my wife is kind of one of those people that she had gone to physical therapy and they told her to do planks, right? That's good for your back. And I asked her if she was doing her exercises, and she said no. And I said, why? And she said, because they hurt. And I said, they hurt how? And she said, it hurts my back. It makes my back feel worse. And I was like, well, that's off the table, right? Like, so you're good to not do that exercise. But what we haven't then given to her was what she could do that wouldn't hurt her exercise. And I think it's careful. You got to be careful at the end of it, even from physical therapist perspective, which is, let me work on you, let me treat you, and then let me just rattle off some exercises that you've heard of that you should do because they are general and blanketed statements, right? And planks would be one of those that gets put out there. And I'd like to submit for your review here that planks are actually a high challenge exercise for the majority of the population, even without low back pain, that could start to peak some low back discomfort. So, you know, there's some exercises that need to be done. There's some stability training that should be out there. But first things first is that if you give somebody something that hurts them, it's not the right exercise. And that should be your first indication, not whether or not they're in good form. Kind of like an overhead squat assessment. If somebody does an overhead squat assessment and it looks perfect, but they stop, and you say, why did you stop? And they say, it hurts my knee. And you don't go, look, what a wonderful, perfect overhead squat assessment. You say, no, this is, I asked you to do 5, you did 2, they look good, but here's the bottom line answer. You couldn't do it because you got hurt. There's pain associated with it. Does that mean then we take that client and says, even though it's a good looking squat, let's go put the bar on and continue to work out? Pain is the number one indicator of stopping, not poor movement. So we have to address the pain in the room and then associate that with exercises that are vital to help support them. And that, as you spoke about, that N of one, that individual approach to it. But what you can't do is give somebody an exercise that's supposed to work that doesn't.
Yeah, and I think that that's important, and what you're saying is so true. Sometimes when it comes to the initial phases of someone who has low back pain, you have to let pain be your guide on some things. Does that make sense?
Yeah.
And now we're talking about more like a known back problem. There's other diagnoses like chronic low back pain and all that, which would be handled maybe a little bit differently. But when we talk about our typical, someone who has a bulging disc, someone who has nonspecific low back pain and stuff, we have to respect pain because that's the body's way of telling the person that something is abnormal. It's not feeling good. Mm-hmm. Okay. And that's why I brought up kind of a little bit about the signs and symptoms, about feeling like the numbness and tingling down the leg. Because if someone's training somebody and they say, okay, the orthopedic says that I have a disc bulge at L3, well, it's good to know kind of like where the tingling leads and all that, so that when you're training the client, if all of a sudden they're getting symptoms, you can ask them what's going on. Because, if they're saying, oh, I'm having pain, well, is it more muscular fatigue, kind of like acute muscle soreness? Or is it that same numbness or tingling that they feel when they hurt their back? Does that make sense?
Yeah.
So they have to decipher what it is. And so I think in general, just, pain being the guide, and also making sure that, pain-free exercises tend to be the best from that.
Yeah. And to point out too, like I tell people all the time, if it hurts in the joint, it's not good. If it hurts between the joint, right? If it hurts between joints, so a muscle, like your quads are burning, that's not a bad thing. But this tingling, this numbing, shooting, those are all things that aren't normal feelings. So there's a difference between the burn of a workout and a neural stinging, burning feeling that should be an immediate stop sign for what we're doing. All right, so let's go to bullet points again. I want to know again what we've got on the list, and let's get to some of these other things that we need to know about, and then let's provide some application once we get through them.
Sounds good. Okay, well, I think the next one kind of on my general list would be, we have to respect too that sometimes the sacroiliac joint can also be affected.
That thing?
Yes, I know. It's such a tough one, the good old SI joint. And a lot of times too, SI joint pain can replicate low back pain. So SI joint pain can refer pain right over the SI joint, but it can also refer pain all the way down to the knee. Okay, so we have a crossover. So that's why with degenerative disc disease, I kind of brought up to say, hey, look, the lower the issue is, it can go all the way down to the foot. The SI joint only goes to the knee. So there's a little bit of a crossover here. So regardless, though, the fitness professional needs to treat it pretty much similar, right? We need to treat pain as almost like a lumbopelvic hip complex pain. But a lot of times SI joint pain can be caused by what we call the pelvis or the innominate out of position. Like a malposition can cause that. A lot of practitioners still call it piriformis syndrome. Okay, or they call it, a pelvic rotation. They call it a pelvic obliquity. There's a lot of words for that, but
I like that.
Yeah, I know, and all these big fancy words, and but a lot of times I work with runners. On the street a lot, and the street's cambered, obviously.
Yeah.
So it's not uncommon for one of their pelvis to kind of be off, and all of a sudden they get those muscle imbalances, and then we're having to reset the pelvis, and then also maybe do an adjustment to get the pelvis aligned. So SI joint is another thing that the fitness professional should consider and just kind of understand, because so when we talk about non-specific low back pain, we know that there's really no origin. We can't really say it's caused by something. When we talk about degenerative disc disease, we know that that's more of like an aging process. It's wear and tear. Okay, and we know that some of our sedentary individuals get it between 30 to 50 the most.
Yeah.
Okay, sacroiliac joint is going to be more of it's going to be lower, like along the tailbone, and then that's going to be really specific to that area, which it may give some pain referral, but it's not going to give the numbness and tingling like the sciatica type of thing that you would feel with some type of disc issue.
Interesting. Now, would that also be? I have people that have come in the past with pain that's almost like a glute medius. It's lateral ilium, but a little more towards the posterior side. Would that potentially be something like a referral pattern for SI joint, or might that just be something different? And of course, you'd need to assess, but just
yeah, there's some general overlap. I mean, I think a lot of times the deep 6 external rotators, okay, below the gluteus, the piriformis, the Gamilli brothers, and the obturators, all of our deep rotators, those attach right on the sacroiliac. So you are going to have that same kind of tight referral and stuff. And a lot of times with the SI joint stuff, a lot of times they're just going to kind of complain of kind of like deeper kind of tush muscle soreness, like you said. And a lot of times you can stretch it out and you can stretch the hip flexors and kind of restore that the pelvic symmetry by doing your inhibiting and your lengthening exercises and stuff. So a lot of that's good. But I think it's important for the FitPro to help to kind of decipher what's going on between low back and sacroiliac. I think that's important to do with that.
Something that's kind of interesting. You talked about the rotations, and I tend to look at something and say, this side interiorly rotated, and somebody else might look at it and say the other side is posteriorly rotated. We're talking about the ilia here, right? So you've got the innominants there, and you're doing an assessment on whether or not you have a kind of a level pelvis, and you might have an anterior rotation. I tend to be rotated on my left side to the front, but I might have another therapist that comes and looks at it and says, well, you're not rotated on the front. You're not anteriorly rotated on your left side. You're posteriorly rotated on your right side. Is that just kind of this oblique rotation that tends to happen where both answers are the right answers? Or is one actually rotated and not the other? Just what are your thoughts on that?
Well, the diagnostics are terrible. I mean, I'm just being honest. If you look at the research, no one can decide which is rotated and which is not. Does that make sense? So if you're rotated, if you're anteriorly rotated on one, you're going to be posterior on the other.
Okay.
Yeah, so that's why we call it Pandora's pelvis, because it's so difficult to treat sometimes. But a lot of times, in my treatments, I don't go straight to like a manipulation. I'll clear the soft tissue first.
Oh, yeah.
So I'll restore muscle symmetry, and to me, that takes care of it most of the time.
Excellent. Yes, and I agree with that. It is kind of interesting where I might even work with somebody and just stretch muscles that are associated with a rotation one direction or the other, and retest the pelvis. Go to the ASISs, PSISs, and find that they're level without anything but some stretches that may have taken place.
Yeah. All right. So why don't we cover 2 more bullet points, Rick, if we could, and then then we'll get to some applications so we can do some take homes. So the other 2 kind of general classifications would be what you mentioned would be an instability, right? That means that the integrity of the vertebrae itself. We call it like a spondylosis to spondylolisthesis, or they simply call it a spondy. There's a cascade of degeneration that occurs with the vertebrae, and the vertebrae can eventually get cracked and become a slippage. Okay, we see this a lot in gymnasts. Okay, gymnasts who do a lot of grinding of the spine, a lot of hyperextension and stuff like that. So we do see this a lot in our hip hop dancers. We see it a lot in our gymnasts and stuff, where they develop this whole it kind of ends with what's called a spondylolisthesis, where they actually get a slippage and stuff. Okay. So that's considered an instability. Okay, and so that has to really be stabilized through a good, deeper abdominal core co-contraction. Does that make sense?
Yeah.
You have to really, because every time that vertebrae slips back and forth, that micro instability, that will definitely fire up the nervous system. And so people get a lot of neurological symptoms, especially pain. So that's a whole nother kind of world that we could always talk about down the road, dealing with instability, because it's definitely a challenge, because most of the time our spine loves to go into that lordotic curve, as you know, right? And we bend a lot from our spine. Well, an instability can be very challenging if it's not taken care of correctly. So it's kind of a whole nother beast per se that you have to deal with. Okay. All right. And then our last one would be, one thing to think about is chronic low back pain. And I think that this is different from all the other diagnoses we talked about. Is this is somebody who's had maybe a long-standing issue with low back pain. Now, chronic low back pain, by definition, is considered pain that has lasted longer than 3 months.
Okay.
Okay. And so what happens is, just in general, if you look at pain science, just talking just very plainly, someone who's been in pain for that long starts to have adaptations in their nervous system. They start feeling it more emotionally. It becomes physical, and actually it becomes metaphysical. It becomes psychological. So metaphysical would be physical, psychological, and emotional. Okay. It starts encompassing their lives. So when you're dealing with somebody with chronic low back pain, the simplest maneuvers could trigger them. Does that make sense? So, and I know a lot of fitness professionals out there work with people with chronic low back pain. And when I interface with them, they have the same story, is that it's more difficult because everything is painful. So you need to switch your approach more on function versus dealing with pain. Now, obviously, if the pain spikes too high, obviously you have to manage it and be safe. But a lot of times they might have this low-grade discomfort with certain maneuvers, but you still have to try to work through things a little bit. It's a little bit more of a delicate topic than your simple non-specific low back pain or your disc issue and stuff. So that's why I think this is such a timely topic, because on social media there's a lot of great suggestions, but those aren't specific to the person.
Right.
And I think this is why this is such a great topic to discuss, because as we mentioned, our bullet list, look how many classifications are just under the umbrella of low back pain. It's crazy. It's a lot to handle. And so those are the main things, I think. And obviously there's other diagnoses, and we can talk probably a whole nother 3 hours about everything, but those are kind of the main ones that I think people deal with as a fitness professional and also as a health professional.
Okay, well, I want to ask a couple of questions, and this will go into just practical exercises that personal trainers can do. And it goes back to something I've done a podcast on in the past, and it's the difference between bracing and drawing in, and that drawing in maneuver, sucking the belly button in. And then there's another exercise that seems to, it's a relatively old one, but it seems to be making such an incredible comeback called, and I'm not sure if you're familiar with it, but it's called the Lewitt exercise, where it is kind of a very forceful exhalation in order to increase activation around the spine. So can you just speak to this idea of drawing in, the idea of bracing, and if you're familiar with the Lewitt exercise, to speak to that as well?
Yeah. Okay. So there's two camps. There's two camps that came out over the last 10 years. The first one is drawing in, almost like sucking in your belly button, like if you're going to do, like Pilates or something, kind of drawing in. Well, that activates, by drawing in, you activate the deeper core. Okay. And it's important for fitness professionals to understand that the original research on low back pain that came out, 20 years ago was on activating the transversus abdominis. Okay. The deeper core. Well, that, along with the internal obliques, actually attaches to the lumbar spine. Okay. So by drawing in, you stiffen up the lumbar spine. So if you have an instability, or if you have a degenerative disc that's kind of unstable, if you suck in the belly button and activate, you create stability. So we've learned over the years that drawing in has some good research behind it to actually relieve symptoms of low back pain in general. Okay, but then other experts like Stuart McGill, all these great minds coming out and saying, okay, well, if you suck it in, that's fine. But what about the 360 corset that has to be activated on the spine? And that's where bracing came in. Okay, so bracing came in where they started looking at where, let's say, for example, you would do the plank, you would arch the back a little bit to tighten up the back muscles, like the multifidi, the back extensors. But then you would also activate the anterior muscles, so that bracing creates this 360 kind of effect. Okay, and so that's kind of in short for the viewers here who haven't had that. And again, it gets a little bit deeper as far as the philosophies, but believe it or not, the research is kind of 50-50 on both of them. They both seem to be effective when you look at that. And we did a systematic review on this, and we looked, and the research on both of them are both good, because I think you're activating the core. And and believe it or not, if you think about it, if we do a plank, we counted over 80 muscles working with a plank.
Wow.
Because think about the 26 core muscles, the feet, the legs, the arms. You're working a bunch of muscles. So most of the time when we do the drawing in or we do the bracing, we're doing it with an exercise. So the muscles are actually activating. So what we do is we first teach the drawing in maneuver supine. Okay? All right, we usually start supine when we're working with anybody, and we'll do kind of like the dead bug sequence or the alternating arms and legs. That kind of creates movement. But we also teach diaphragmatic breathing. Does that make sense? We also teach them to breathe properly. We teach them to activate. Then we move to, we can do that. Then we can move to prone if we want to. We can go to quadruped, and then we can do sideline, standing, whatever progression you want. But typically we start with the drawing in, and then we move to actually combining the drawing in with the bracing at the same time.
Gotcha. I like that. And then I want to speak to, just real quickly, to the Lewitt exercise, which has been popularized by some education courses that are out there right now. And there was a doctor years ago that had come up with this idea. His last name is Lewitt, and he was a colleague of in the cohort of study with Yonda. And Dr. Carol Lewitt is his name. He's a Czechoslovakian neurosurgeon. And let me just walk you through this. And this is interesting because here's a research study done by one of the authors is Stu McGill. And it was cool because, Stu McGill is brace. Just brace. Everything's about bracing and stiffness of the core. And they said in here that they really didn't know the Lewitt would be very effective. And the Lewitt exercise is where you kind of lie on your back, your hips are at 90 degrees and your knees are bent at 90 degrees, and maybe your feet are on a bench or a table or something like that. And you take a deep breath in, and then you blow out. And usually the technique would be like a small hole in your lips, like there's a straw, and you push out of that small hole as hard as you can until you have exhausted the majority of your air. And this research study showed far more increase in the internal obliques than did drawing in or bracing, or far more in external obliques, far more activation in the rectus abdominis. It was really an interesting thing, and so I've added this to my arsenal because not many people are familiar with it. People don't really know about it that much, but this practice of forceful exhalation that activates your core, I thought was really good, and I found it to be really effective with some of the folks that I work with. And talk about feeling the activation take place. It's also something that you can do that's not dependent upon whether or not you can get it, right? Like, I don't really get bracing. Well, this one you get it because there's something else to focus on, which is just exhaling as much as you can. And so great exercise, something that's kind of nice to add to it. But again, it's not based on any particular way of getting out of low back pain. It's simply a means of helping to stabilize and activate the core musculature.
Yeah, and I think I did read that study, and it was interesting because I really would like to see more, like with control group research, more controlled studies on that to see, because we always teach clients to exhale whenever they push or they pull, right?
Yeah.
Right. So, pursed lip breathing, what we talk about, that's very common with pulmonary rehabilitation.
Mm.
And so that fires that whole diaphragmatic area and all that. So when I read it, it made sense. But yeah, I would love to see more of an EMG study, more of a, controlled in different positions and stuff, especially with gravity, right? Supine, sideline, prone, and standing. I think it'd be interesting because obviously when our body is orientated with gravity, the muscles function differently, right? And stuff like that. So yeah, I was definitely impressed with that. It's a neat idea, and for Stu McGill to get on that and really kind of give it a thumbs up, it was interesting because again, everything's bracing with him, right?
Yeah, for sure.
You do dishes, you have to brace, right? You know what I'm saying? It's like everything's like, so I think there's a lot we don't know about the body,
Sure.
and especially with like low back pain and this whole thing. But I think we do know in the research and stuff that patients with low back pain typically present with like a lower cross syndrome. We understand that there's muscle imbalances. We understand that people with low back pain, their back muscles atrophy, right, because of the pain.
Yeah.
Their cores turned off. So exercises, we know that abdominal core exercises do help people with low back pain. So I think, like you said, the Lewitt exercise is just one more tool in your toolbox to help clients get better. But as we mentioned throughout this whole theme is we need to respect the different sub-diagnoses of low back pain, but also respect pain, right? Pain is our guide, just kind of in general, just to be safe.
Yeah, and one thing I want to drive home, which is the focus that we have in corrective exercise, which is the corrective exercise model is identifying what we can do from our perspective, which is because you said posture, right? So this is very important. What muscles are presenting as tight? So there's an assessment that takes place. From that assessment, we identify short, potentially overactive muscles, and we do some type of inhibition to those. We do some type of static stretching to allow for lengthening. And then we give strength to the other side of it. And then things like integrating exercises together so that the weaker muscles and the overactive muscles are learning how to better communicate and realign and allow for movement to take place. And from a personal trainer's perspective, our job is not to get people out of pain. But if we can provide corrective exercise and help people move better, and by implementing that, we mitigate that pain, there's nothing wrong with that. But we're not going into battle trying to say, I'm here to get you out of pain. We should never speak that. We should never put that on our business card or have it on our website. That shouldn't be a goal of ours. It might be an outcome, but that should not be a goal of ours.
Yeah, and I agree, because I think one rule of thumb I always tell the fitness professionals that I refer to is just pick up where I left off. Does that make sense? That's the safest rule of thumb for anybody. So if your client, if your client has seen a physical therapist and the physical therapist has got them kind of stable enough to go back to the gym, you simply just hopefully communicate to the physical therapist, say, hey, what did you finish doing? And then just kind of continue where they left off. And then you can do your corrective exercise assessment and you can go through things. But in general, people with low back pain, they're going to have a lot of correctives that can be done by the fitness professional. Trust me, there'll be plenty of tight muscles. There'll be plenty of bad posture. Their movement testing is going to be all kind of, a little bit impaired because of the pain and stuff. So there'll be plenty of stuff to work on. I think when we try to diagnose beyond our scope of practice, that's what gets us in trouble.
Yeah, and that's definitely not what we do, right?
Well, and
right?
Think
everybody
about
listening, that's not what we do, right?
Yeah. Well, and then Rick, think about this. If all the experts in this world can't figure out low back pain,
yeah,
right? Stuart McGill, who has over like 300 studies on low back pain, he's still trying to figure it out. So that's why it's such a touchy subject, to where we need to be more individualized. And when we're sharing information, be careful with throwing out, especially to our clients, providing a diagnosis or providing a recipe if you don't know 100% of what's going on. And
Right.
I think that that's important, because like we talked about, there's so many causes of low back pain. We just have to respect that we have to take it one step at a time with our clients.
I like it. All right, Scott, thank you for that. Let's go to Greg, and if you guys have time, because I know we're running
I definitely have time.
late getting started. Greg, are you okay time-wise?
Sure.
All right, let's
It's your
do
show.
it.
I'm just here to serve you.
Yeah.
Yes, Rick.
You
Rick
actually have a real job somewhere to do, and I don't want to
Yeah.
keep you from doing it.
Real is
all of our
debatable.
viewers. We're good. Yeah.
All right, Ben. Do you have any questions that happen to have popped up whilst we were speaking?
Yeah, and hopefully they're all within scope of practice, and if not, you can yell at me. That's fine. Danielle wants to know, can you give some examples of good exercises for someone with low back numbness and healing from a coccyx injury? No known cause to the pain. They've already seen an MD.
Wow. Okay, because that's a tough one. So if we talk about a coccyx injury, we talk about the tailbone got smashed. Okay, so the sacral plexus, you have S1, 2, 3, 4 in there that gets kind of damaged. So that's going to be something that it's going to be very difficult to answer, because any type of squatting, any type of movement of the SI joint coccyx is going to be very painful. So I really believe that any type of lumbopelvic hip issue, taking a core-based neutral spine, kind of a neutral spine approach, will be the best. The coccyx injuries that I do work with, I have one right now currently, they tend to be very painful when you go into hip extension, like doing butt bridges, any type of compression on that, any type of crunches or sit-ups. So I would avoid any type of pressure to the coccyx. I think standing exercises, single limb motor control stuff, like single leg squats and stuff, could be a good approach to that role.
Right. So be careful and don't hurt them.
Yes.
Okay.
Yeah, and her question is really challenging, because the coccyx injuries are so painful. Oh my gosh, it's really tough. But any type of compression on the coccyx with like a crunch or something where you're on the ground, or really forced closure of the SI, is going to be very painful on that.
Gotcha. All right, Greg, what else you got, sir?
Well, first off, I'm just glad I said coccyx, all right? That was a win. So look at this, my college education paying off. And then Christine wants to know, what is your take on crunches for clients with lower back issues?
Okay, well, as we know too, and I'm not going to get too much into it, but when you do a crunch, we know that the anterior abdominals fire. The back muscles have to relax, and that's called deflection. The flexion relaxation response. So you decrease stability in the low back through doing crunches. So a rule of thumb is, somebody with low back pain doing full sit-ups is not very good, or doing advanced crunches is not very good. Okay, so when I get somebody with low back pain, I'll do crunches where the shoulder blades come up off the floor per se. So I'll go from 0 to about 30 degrees, because that fires the rectus abdominis. If you go 30 degrees or higher, you start firing the hip flexors when you're doing a crunch. So those are kind of the rule of thumb. So that's how I would approach that.
Okay.
And then one final one in the chat. Jara wants to know, says the information on the SI joint was great. What are some good stretches or exercises to help with that?
Okay. One thing that I see too, a couple things, is that when someone is suffering from some type of SI joint issue, or they've seen a diagnostician, they say that they have a rotation, a lot of times, in my opinion, the rectus femoris and the iliopsoas are overactive and tight because they're being pulled. So I think it's more of an anterior hip problem. I think they're going to present with the lower cross syndrome. So I think a lot of inhibiting and stretching of the rectus femoris and the iliopsoas is going to be the key to that. That's what I do. So any type of SI joint stuff I have is I'll usually do my manual therapy, and I'll calm down and, let's say per se, just quickly speaking, loosen up the front anterior hip. Then I'll retrain the posterior chain. Okay, so I think as to answer the question, that's going to be the most important thing, is trying to stretch out the front, reactivate the back, and then also we also can't forget where the TFL, the gluteus, the hip abductors, and also the hamstrings and the deep rotator. So we need to do general stretching around it, but I would focus on clearing and trying to calm down the anterior hip muscles. That's my approach.
Excellent. All right, Greg. So that's it for the questions. Greg, thank you for chiming in.
I lied. There's actually one more if you got time, guys.
Oh, sure.
Somebody snuck in at the last second. Roberto wants to know is it true that deadlifts can help strengthen the lower back?
Well, I mean, there is research on squats and deadlifts, and we have to remember that our prime agonist movers to a lot of our squat motions are going to be coming from the glutes, the quads, hamstrings, calves, and that a lot of times our spine, even if we're hip hinging, is going to be isometrically stabilizing. Okay, so there are going to be some crossover with muscles like the multifidi, the quadratus lumborum, some of our glutes and stuff like that. So there is going to be some strengthening going on, but it's not like if I do a bunch of deadlifts that all of a sudden my low back is going to be totally strong. Does that make sense? So there's gonna be some crossover, but a lot of times though those primary muscles are the focal point of any type of squat exercise, like deadlifts, good mornings, RDLs, squats, etc. So
all right, well, I think that is a great answer, which is it's good for your back, it's a stabilizer. And I wouldn't necessarily jump immediately to that if you've got somebody that has low back pain or low back discomfort. That there would be a continuum to take somebody on, and I would put those deadlifts kind of at the tail end once you go through a series of other exercises.